Picture this. It's 2 a.m. in the emergency department. A 28-year-old guy walks in, completely doubled over in excruciating right flank pain that's radiating right down to his groin. His urine dipstick shows microscopic hematuria. Naturally, he's quickly diagnosed with a past kidney stone, given some tamsulosin, and sent home. But 2 weeks later, that exact same young man is admitted to the ICU. He's got severe shortness of breath, he's coughing up blood, and a chest X-ray reveals multiple bilateral pulmonary lesions. So, what went wrong? Well, he never actually had a kidney stone. Welcome to this explainer on mastering testicular cancer, where we are going to completely unpack how this dangerous clinical trap happens and exactly how you can avoid it.
So, what was actually causing that flank pain? It wasn't a stone. It was acute retroperitoneal lymphadenopathy compressing his right ureter, driven by a primary non-seminomatous germ cell tumor. He actually had a stony hard testicular mass that he'd been hiding for months out of embarrassment, and it had rapidly spread to his lungs. The major board and ER trap here is that testicular tumors are notorious shapeshifters. Literally up to 20% of patients present primarily with systemic, metastatic, or non-scrotal symptoms. Think back pain, gynecomastia, or, like our guy, flank pain. Missing the physical exam of the testes in a young male with unexplained systemic symptoms is a classic yet totally preventable diagnostic failure.
Okay, let's dive into this. Our roadmap today covers the biology of germ cell tumors, history, exam and anatomy, markers and fertility, the radical inguinal orchiectomy, post-chemotherapy and RPLND, and finally, clinical advances and a summary.
Starting right off with Section 1, the biology of germ cell tumors.
Testicular germ cell tumors, or TGCTs, are actually the absolute most common solid malignancy in young men aged 15 to 40. But here's the incredible news. Despite their aggressive potential, they are a massive triumph of modern oncology. Even with metastatic disease, overall cure rates exceed 90 to 95%. But achieving that relies entirely on precise, early decision-making. To master this, you kind of have to split testicular cancer into two distinct biological personalities. Think of seminomas as monolithic oak trees. They grow somewhat predictably. They tend to stay localized in the retroperitoneum for longer, and they are exquisitely sensitive to radiation and chemo. You hit them, and they just collapse. On the flip side, you've got non-seminomatous germ cell tumors, or NSGCTs. These are the wild weeds. They're aggressive, biologically unpredictable, they spread early through both lymphatics and blood, and they often contain primitive elements like teratomas that are basically immune to chemotherapy.
Now, dropping down to the cellular level, over 95% of these tumors arise from a common precursor called germ cell neoplasia in situ, or GCIS. During fetal development, primordial germ cells fail to differentiate and basically get arrested. They just sit there, totally dormant, until puberty hits and hormones like LH and FSH wake them up. If you look at the genetics driving this, over 80% of invasive TGCTs show an amplification of isochromosome 12p. This single-cellular misstep dictates pretty much everything we're about to see clinically.
Moving right along to Section 2, history, exam, and anatomy.
Okay, this is an absolutely crucial point. You must never, ever perform a transscrotal biopsy or make a scrotal incision for a suspicious mass. Think back to fetal development. The testicles originate near the kidneys around the L2 level, and they drag their primary blood and lymphatic supply all the way down with them. That means the testes drain directly into the retroperitoneal lymph nodes. The scrotal skin, on the other hand, drains to the superficial inguinal nodes. So if you cut through the scrotum, you breach the tunica dardos barrier. You instantly cross-contaminate the superficial inguinal lymphatics with tumor cells, which completely alters the patient's biological staging. It is literally a surgical sin.
And since a biopsy is totally out of the question, your physical exam has to be flawless. First up, by manual palpation. You want to lock the normal, soft epididymis posteriorly and feel the mass. A true tumor feels stony hard and is completely inseparable from the testicular tissue itself. Second, use a pen light in a dark room for transillumination. Fluid-filled cysts will glow bright red, but a solid malignancy absorbs the light and stays dark. Finally, don't forget your systemic checks. Palpate the left supraclavicular fossa for Virchow's node, and always check for bilateral gynecomastia, which can actually be driven by really high beta-8-CG levels.
Next up, Section 3, markers and fertility.
Now here is a golden, unbreakable rule when it comes to alpha-fetoprotein, or AFP. Notice that pure seminomas never produce AFP. They're always normal. So if you get a pathology report back that says pure seminoma, but the patient's AFP is elevated, that tumor is automatically reclassified and treated as a non-seminoma, no exceptions. Beta-HCG can be elevated in both types, but if you see massive elevations, like over 50,000, that strongly points to choriocarcinoma. And LDH, it's really just a non-specific marker that gives us a broad sense of overall tumor burden and cell turnover.
But before we even think about rolling into the OR, we have to talk about fertility. Sperm banking is what we call step 0. You absolutely must offer semen cryopreservation prior to orchiectomy, chemotherapy, or radiation. Why? Because up to 50% of testicular cancer patients already have impaired baseline fertility from tumor-related stress or genetics. If a panicked young patient says, "Just take the tumor out, I don't care about kids right now," you have to hit pause and protect their future self. It's a completely non-negotiable insurance policy.
Which brings us to Section 4, the radical inguinal orchiectomy. The gold standard procedure here is a radical inguinal orchiectomy. We make the skin incision way up in the groin, parallel to the inguinal ligament. We open the canal. And then, before we even touch or manipulate the testicle down in the scrotum, we do something incredibly important: early vascular control. We clamp the spermatic cord right at the internal inguinal ring. By isolating that blood supply first, we make sure no malignant cells get squeezed into the bloodstream while we're mobilizing the testis. Then the cord is doubly ligated, and the entire specimen goes to pathology intact.
Section 5. Post-chemotherapy and RPLND.
Depending on the initial staging, a patient might need chemotherapy. But what do we do if a mass is still sitting there in the retroperitoneum after chemo is totally finished? Well, this is where the treatment paths diverge drastically. Seminomas are so exquisitely sensitive to chemo that if a residual mass is under 3 centimeters, we usually just observe it. If it's over 3 centimeters, we'll check an FDG PET scan. But for non-seminomas, we follow the 1 centimeter rule. Any residual mass strictly greater than 1 centimeter must be surgically removed via a retroperitoneal lymph node dissection, or RPLND. We literally cannot just watch it. And why is that? Because 40 to 50% of these masses are mature teratomas. Remember those wild weeds? They are totally chemoresistant and can actually undergo malignant transformation into sarcomas if they're left behind. They are ticking time bombs.
Now, when performing an RPLND, the surgical team is up against a massive functional challenge. The retroperitoneal great vessels are basically an 8-lane highway, and the tumor tissue is like thick vines wrapping all around it. But running directly behind those vines are the incredibly delicate L1 to L3 lumbar sympathetic postganglionic fibers. You can think of them as microscopic fiber optic electrical conduits. These specific nerves control emission and ejaculation. So, a nerve-sparing RPLND involves painstakingly dissecting these fiber optic cables away from the tumor vines. It's tedious, but it preserves a young man's fertility and quality of life without sacrificing the oncological cure.
Finally, Section 6, clinical advances, and a quick summary. So while traditional markers like AFP and beta-HCG are absolutely foundational, the newest frontier in urologic oncology is a liquid biopsy marker called circulating microRNA 371A3P. This biomarker is proving to be a real game changer, demonstrating greater than 90% sensitivity and specificity for detecting active germ cell malignancies. It vastly outperforms our traditional markers and is genuinely set to revolutionize how we diagnose and monitor both seminomas and non-seminomas very soon.
Let's bring this all together with a quick, rapid revision matrix. Remember the Great Divide. NSGCTs tend to hit a bit younger, around 20 to 30, while seminomas peak a little later, around 30 to 40. For markers, if you see an elevated AFP, you are looking at an NSGCT, period. When it comes to treatment, seminomas basically melt away with radiation and chemo, while NSGCTs harbor those stubborn radioresistant teratomas. And because of those teratomas, remember the rule, any NSGCT residual mass over 1 centimeter after chemotherapy demands a surgical RPLND.
We started this explainer with a young man whose systemic symptoms completely hid a dangerous testicular tumor. But now, you've got the blueprint to catch that diagnosis early. From understanding the strict L2 anatomical drainage that strictly forbids scrotal biopsies to enforcing the 1 centimeter rule post-chemo. So, the next time you're on a ward round or working a chaotic late shift in the ER, how are you going to apply these rules to make sure a scrotal mass is never missed or mismanaged? Keep these frameworks in mind, and you'll handle these cases with absolute confidence.